Good morning again. My second presentation is going to be about endometrial carcinoma, and I will try to give you an overall view of what happened with our interpretation of endometrial carcinoma over the last, say, 30, 40 years. I'm sure, is it? Can I have the pointer of the slide advancer here? Yeah. Where? Is it here? I have problems with the careful, not like yesterday. Okay, so. But essentially, this is the outline of my presentation. We're going to see how we move from type 1, type 2, these dualistic things. I parenthetically said, be careful about those dualistic theories or concepts, because they are, most of the time, they are artificial. And as a matter of fact, in endometrial carcinoma, we have moved from 2 to 4 to the so-called TCGA, the Cancer Genome Atlas, which is an integration of genomic, transcriptomic, and proteomics, so all you can think about in endometrial carcinoma using clustering and then, sequencing. By doing clustering and sequencing, that means where does this tumor goes, into this cluster or that cluster. And sequencing, seeing the alterations systematically, we reclassify endometrial carcinoma into 4 types, but I'll make it easier for you. From Bogman's classification, type 1, type 2, 1983, to the 2013 TCGA, okay? 4 types. And then the pathology, the diagnostic categories, which I mentioned yesterday, that morphology is the one in command. It's number 1 criteria, morphology. Then once you have classified them morphologically, then you can add molecular genetic alteration. But morphology in clinical medicine is the most important of the whole thing. So it's your reference point, right? And then we discuss, if we have time, the interesting group of mixed endometrial carcinomas. Be aware of these mixed tumors, because they are moving. They are changing from good tumors to not so good to very aggressive tumors. So when you have a mixed endometrial carcinoma, chances are the prognosis is going to be bad. Huh? And then how is FIGO doing regarding all these changes? And I don't think FIGO is doing that well. Mm-hmm. Now, is it there? Huh. I'm sure you haven't seen this before, right? The type 1, type 2, which was done on the clinical basis by a gynecologist. No pathology here. Just a gynecologist who decided to classify endometrial carcinoma based upon estrogen's effect or not estrogen effect. And that was Bogman in 1983. He identified a group of patients with evidence of estrogen, unopposed estrogen present, and so these tumors had, the patients have these features of estrogen, hyperestrogenism, right? Obese, diabetes, hypertension, all that. And then, whereas the other group, which is a smaller group, right? The patient didn't have evidence of hyperestrogenism. They were thinner. They were a little older, and then the pathologist came and identified 2 different types, right? The one resembling normal endometrium, and they call endometrioid carcinoma, which is this type, in which the grade was low. The myometrial invasion was none of minimal. I alluded already that it was difficult. Well, let's forget about myometrial invasion in this. It's just very little, if any. And they call it endometrial carcinoma. And the behavior was stable. 80% of endometrial carcinoma are this type, and once you do the hysterectomy, the patient is cured. Whereas in the type 2, the appearance of the tumor did not resemble endometrium, right? That's they call non-endometrioid. That's a terrible term because they include serous, clear cell, carcinosarcoma, at least 4 types, no? Non-endometrioid or type 2. It's not adequate. I think you should call these tumors by their names. Myometrial invasion usually was deep, right? Because they were very aggressive. And again, this is non-endometrioid, and the course is progressive. And then, at the same time, or subsequently, molecular genetic studies appeared. And then, look at this. Oh, okay. And there was a clear-cut association between endometrioid and microsatellite instability and P10, CTNMB1, beta-catenin, and other things. You know microsatellite instability, right? Every time the cell gets into the cycle, errors, 600,000 errors are made, and then the repair system, right, that takes care of those errors. When the repair genes and the proteins coded by these genes are out of business because of germline or hypermethylation of the promoter, then you have errors that perpetuate, and then accumulation of errors, you got cancer, okay? That's microsatellite instability. It could be inherited, Lynch syndrome, or it could be sporadic, like hypermethylation of the promoter, promoter hypermethylation. Whereas in the second, the typical genetic alteration was P53 mutation. Not too many mutations in the second, but always one, P53, always there, right? Mutated. And then losses and gains. This is a crazy tumor. It's similar to the one we discussed yesterday. Remember high-grade serous carcinoma? How chaotic, great losses, great changes. So you got the morphology is horrendous, a very high grade. Why? Because it's very abnormal. Huh? So triple negative in the breast, high-grade serous carcinoma in the ovary, and this one in the uterus, serous, we don't call papillary, please. Everything is papillary. All the carcinomas are papillary. In the ovary, in the endometrium, so forget about the papillary. This is serous. In the ovary, we call high-grade serous. Here, we call serous, period. Okay? So this is serous, this is endometrium. But other than serous, we have clear cell, we have carcinosarcoma, right? Other types. The bad types, bad actors. All right. And then here's the cartoon where you can see the features. Okay. How is this tumor? Non-invasive, right? How is this? Invasive. This resembles endometrioid, right? Glands, endometrioid. This does not resemble endometrium, very big nuclei, non-serous, right? And then microsatellite instability and P53 immuno and the mutation, right? So you got here the robot picture of these tumors. And now there is a different way of looking at it, because these was 80% or more of the endometrial carcinoma, the one on the left, whereas this was only 10%. But when you look at it from the death rate, you know how it changed. Many patients die of serous, whereas not so many, some die of endometrial carcinoma. So serous is a serious thing, okay? All right. Now, let's look at quickly the the molecular genetic alteration. Look at how different they are. When you look at endometrioid, the ones resembling normal endometrioid, what do you have here? You have exactly the changes we discussed yesterday. You have microsatellite instability, P10, KRAS, beta-catenin, CTNMB1, ARID1A, which is a suppressor gene that is associated, we discussed that in the ovary yesterday, clear cell and endometrioid is seen mutated in the type 1, in the endometrium. Whereas these very same alterations rarely are found, or less commonly, less frequently are found in the type 2. I'm sorry, I should point it out here. Okay? Type 2. Well, the type 2, what does the type 2 have from the molecular genetic? I already said P53 mutation in almost 100% of the cases, and other things which are amplification. What is amplification? Well, you got the number of copies is increased, very many copies of the alteration. This is characteristic of the type 2. Whereas in the endometrioid, these They also occur, may occur, but much less frequently, as you can see here, P53, P16. And we're still with the type 1, type 2. We haven't arrived to the TCGA, which really reinterprets these findings in the light of all these examinations that they have done. Okay. Now, as everything in life, you know, I know some people like to have black, white, good, bad, benign, malignant. It's easier. But it's not that easy. There's a lot of gray. And if you have 1 and 2, you're going to have a 3, a third type. And that is usually the result of overlapping, as shown here. There are true endometrial, there are true non-endometrial, but there are also a third type, which is sort of in between, overlapping. The one we pathologists have difficulty. Is it endometrial? Is it non-endometrial? And how do we explain that? Well, we explain that by this, like this. Okay, this is a tumor, endometrial carcinoma, which is papillary, of course. Papillary here, papillary there, all papillary. But notice the difference. This component differs from this one, that this one has humongous, horrendous nuclei. This is serous. And this is small nuclei. They all both have microsatellite instability, both of them. But this one, the one with large nuclei, had this. When we run immunohistochemistry for P53, the one with pleomorphic nuclei, the serous, reacted for P53, whereas the non-serous, the endometrial, did not. How do you explain that? They're all in the same tumor. I mean, the same patient, the same tumor, having this component and that component. Well, chances are this component, the serous, arose from the endometrial by tumor progression. You know, this is the name of the game in cancer. Tumor progression. Tumors do not stay the same, just progress, get losses, gains, and change. And if it can be worse, it's going to be worse. So it's going to be serous from endometrial. And years ago, we explained this picture like this. You know, from normal endometrium through microsatellite instability, PIK3CA, P10, KRAS, beta-catenin, all these changes, you get endometrial carcinoma, the type 1, the one associated with hyperestrogenism. And eventually, more alterations, and eventually got P53 mutation, and this is a way one endometrial becomes non-endometrial, serous, with all these alteration, amplification, blah, 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 blah. Okay? So this is tumor progression. Now, today, before TCGA, and I'm getting to TCGA, but not yet, we pathologists do not have difficulties with grade 1, grade 2. We tend to lump it in low grade. I think, forget about grade 2. 1 and 2 is just low grade. And then they are high grade. And that is the problem, that high grade and serous are very difficult sometimes. Difficult to distinguish. And even if they are clear-cut endometrial grade 3, remember, okay, we say grade 1, grade 2, low grade, and then high grade. If they are high grade for you, grade 3 endometrial, and for me, they may have the alterations that you find in serous and behave like serous. That is the discovery of the TCGA. I'll get into that. So here in this cartoon I put grade 1, grade 2 endometrial, right? And then grade 3, the one we have trouble with. The one we run the slides and you think A, I think B, blah, blah, blah. Okay, and then we have the serous, true serous, which is shown here. Nearby clear cell carcinoma, which is rare in the corpus. It's rare in the ovary, but it's less common in the corpus. But it does exist. And then a category, which I don't have time to discuss, but these very unstable tumors with several components running from one to the other, which are extremely interesting and very heterogeneous. I mean, what is not heterogeneous in cancer? Everything. But these are extremely heterogeneous. So this is the picture. With this picture in mind, look, this is from 1983 until 2013. FIGO still is in 1988. One endometrial carcinoma. Okay? Okay, one. Now we have 4. FIGO, not even 2, 4. 2, 1. Okay. Now, this is the TCGA. The TCGA study, cooperative study, different centers in the United States, studied 373 endometrial carcinomas, most of them endometrioid, 307 endometrioid, 307 endometrioid, resembling the normal endometrium. And non-endometrioid or serous or mixed, there were 53 serous and 13 mixed. That's the thing. In all these cases, they did genomic, DNA, RNA, proteins, histotype, next generation sequence, everything. They did everything, covered the whole thing. And what did they find? Very interesting. Well, I advance. What they found is that this category that was already difficult for him and me to grade 3, endometrioid, part of this category, part of this group of cases moved to a new category called POLE. I'll tell you in a minute. And the other rest, about 25%, moved to the serous. So they were reclassified, rearranged as even being morphologically endometrial grade 3 for me. But they had genetic abnormalities and behavior similar to serous. And they should be treated like serous. This is the whole thing. Okay, here is. Okay, remember we had two types? Okay, here are the two types. Endometrioid, which is shown here. You see how careful I am with this pointer? Endometrioid, right? We had, right? Endometrioid. And non-endometrioid, right? Now, there were two, no? Well, now we have 4. 1, 2, 3, 4. But mind the pies. Mind the pies, because each pie shows the cases that were, coming or moving into from other categories, from the endometrioid and non-endometrioid. In short, we have endometrioid, low grade, high grade, and then the non-endometrioid, serous and mixed. These serous and mixed, the non-endometrioid, didn't really change with the TCGH. The change is here. This is the change, the high grade endometrioid. And notice how many of these cases are reclassified now like serous with the purple, you see, copy number high. Whereas, others are new category called ultra-mutated. I'll go into that in a minute, don't worry. And then others that stay hypermutated, which is the microsatellite instability CTNMD1. Okay, now, notice that in each category, this is low grade, this is high grade, this didn't change much. The low grade changed, particularly the high grade, the endometrioid changed, particularly the high grade, and this change was the introduction of a new category, the copy number high, the ultra-mutated, and the fact that many of these high grade, 25%, move into this category, which is the serous or serous-like. Okay, I'll go into that in a second, like this. Okay, so in short, the TCGA found 4 categories of tumor. The first one is called ultra-mutated. Why? Because there are millions of mutations, okay? A lot of mutations. But one mutation that is always present is POLE mutation. And they are associated with good prognosis. Then the hypermutated category, which is the microsatellite instability. There are many mutations, but not as many as in the ultra-mutated. And then the copy number low and copy number high. The copy number low, the copy number high is the serous. I already said that amplification was the rule here. P53, there are few mutations here, not as many as in the ultra-mutated and the hypermutated, but P53 mutation is always there. And then the copy number low, which is P10 and beta-catenin, and microsatellite instability particularly, and that is the prognosis of this category is shown here, I think, is shown here. The prognostic impact of this new categorization is shown here. You see how the polymutated tumors are associated with excellent progression-free survival, whereas the serous, as already known, are, associated with poor prognosis. Then these new categories, this low copy number, notice that it's very similar to the microsatellite instability, to the hypermutated group, So you have a very good, excellent prognosis, but the interesting part is that these tumors appear pathologically and morphologically as high-grade, grade 3 endometrial carcinomas, you see? And they are associated with good prognosis. So it's worth to make a POL-E analysis, a study, okay? Which is something you cannot do by histochemistry, immunohistochemistry. I'll end up in a minute showing you how we create a surrogate. We're not going to be able to study each case with doing all these things, but we have a surrogate. By doing P53, microsatellite instability, and POL-E analysis, we can tell belongs to what group the tumor is, okay? And here is what we do. These POL-E cases are high grade, again. All of them show POL-E mutations. Yeah, the histologic grade varies, 60%, are usually high grade. And then the morphology, sometimes is ambiguous, creating the question, raising the question whether they are serous or endometrial. These are the POL-E. So once you find here, the POL-E is associated with good prognosis, as shown here in these two diagrams, progression-free survival and overall survival compared to POL-E wild type, not mutated, so much better than mutated than the non-mutated. Even if they have P53 mutation, they can have P53 mutation, but the POL-E mutation takes care of the whole thing. And this is recurrence, much frequent recurrence in the POL-E non-mutated than the POL-E mutated as shown here. Now, how do we do with these cases? Well, we study POL-E by sequencing, and then microsatellite instability by immunohistochemistry and P53. And then we do like this. If the POL-E is mutated, that prognosis is going to be good, and probably it's not worth doing lymph nodes because, even if it is high grade, grade 3 endometrial carcinoma, the prognosis usually is good. There are exceptional cases. I'll comment that in the discussion. Exceptional, but most of these POL-E associated tumors have excellent prognosis. Now, if the POL-E is not mutated, but the P53 is abnormal, it's a serous, right? It's a serous as shown here. Whereas if the POL-E and the P53 are not mutated, right, then you may have mismatch repair, microsatellite instability, which is a case of a hypermutated tumor. And then finally, POL-E not mutated, P53 not mutated, and normal mismatch repair has to be low copy number. So that's the surrogate. I will end up my presentation here. I try to show you how things have moved from two groups, endometrioid, non-endometrioid, which is very artificial, which is very sort of stereotype. And on the clinical basis, which is important, estrogen or not estrogen, how the type 2 hasn't changed much, but how the high grade, grade 3 of the type 1 have moved into the type 2, the serous, or to a new category in which maybe lymph nodes is not worth doing because the prognosis is excellent. That's the POL-E. And pathologists, by doing this, can tell you about. Okay? Thank you.